We will now resume meeting number 34 of the House of Commons Standing Committee on Health. Today's meeting is taking place in a hybrid format pursuant to standing orders. I would like to remind participants of the following points. Please wait until I recognize you by name before speaking. For those participating by video conference, click on the microphone icon to activate your mic and please mute yourself. When you are not speaking, at the bottom of your screen you can select the appropriate channel for interpretation, either floor, English or French. A reminder that all comments should be addressed through the chair. Whenever the honorable member raises a point of order, the person that's speaking, I would request that honorable member to stop right there so I can entertain that point of order. For members in the room, if you wish to speak, please raise your hand. For members on the Zoom, please use the raise hand function. The clerk and I will manage the speaking order as best as we can, and we appreciate your patience and understanding. To the honorable member, because I'm not picking one member or the other, in general I'm saying, because right now when we are not on a subject matter that we are studying, right now there's a motion in place. So I would request all the questions should come to the chair, not to the analysts. Analysts do the non-partisan work. When the study is in place, they provide us all the research, all the material, and I do appreciate that. So that is the time we can always go back to them to ask for help, because now sometimes it becomes too partisan. So I would refrain them to coming in and refrain members not to go to the analysts in those situations. Now, when it comes to the interpreters, I got to consider the health and safety of the interpreters. We're very fortunate we have 3 doctors on this committee. They understand the medical terms very well. But if we have to speak for a long time, if we can slow down the pace so the interpreters can interpret, that would be very well appreciated, and interpreters will appreciate that as well. So if it's one person speaking for a long time, periodically I might give interpreters a health break, 5 minutes, 10 minutes in between by suspending the meetings. So with that, pursuant to Standing Order 108 and the motion adopted by the committee on Tuesday, September the 23rd, 2025, committee shall resume its study of Canada's pharmaceutical sovereignty. Committee suspended its meeting on Tuesday, June the 2nd, during a debate on the motion of Dr. A. Opson. However, I received a request under Standing Order 1064 to convene a meeting to discuss request to study the prescribed IT program. Invite the Minister of Health, Marjorie Michel, and summon the former Canada Health Infoway CEO, Michael Green, to testify as part of the committee's investigation. Procedural reminder. So if the committee has an ongoing yet suspended meeting, according to Section 220.98 of the House of Commons Procedure and Practices, states that it will resume the suspended meeting within the timeline prescribed by the Standing Order 1064 and decide how it wishes to consider the request. It is up to the committee to decide if wishes to consider the request of the 1064 or continue with the debate of the suspended meeting. Therefore, at this time, I would look to see if member wishes to move a dilatory motion to consider 1064. Yes. Okay, there is a dilatory motion, so I will ask the clerk to take a vote on this one, please. Thank you. Mr. Major.
Ms. G.
Sorry, can you repeat what was just said?
At this time, so it is to vote to consider the motion or consider section 1064. So if you
Oh,
want to
thank you, Chair,
consider
yeah.
section 1064,
Thank you, Chair. Yeah, so
you
I
vote
vote
yes
no.
or no. Okay.
Ms. Chi. I didn't
She
hear.
said
No.
Okay.
Okay.
Mr. Elson. No. Ms. Jackson.
No.
Mr. Arana.
No.
Mr. Sawatsky.
No.
Ms. Sidhu.
No.
Mr. Bailey.
Yes.
Ms. Gonans. Yes. Mr. Mazier.
Yes.
Mr. Genius.
Yes.
Mr. Blanchet-Jonca.
Oui.
The motion defeated. Now the floor is going to be with Mr. Bailey, as it was with Dr. Strauss. He's not here today, and my sincere condolences, and of course on behalf of the committee, because his dog passed away. And we have Mr. Janis. Welcome to the committee. So the floor is with Mr. Bailey, then Madam Konas. Mr. Bailey, please go.
Sorry, just a point of order. Before Mr. Bailey begins, I wonder if we could hear what the current list is from the.
Yes,
from the
current list is, it was Mr. Strauss, Dr. Strauss, because he's not here. So I'm jumping to next one was Mr. Bailey on the list, and then Madam Konas.
Okay, then I'm at it.
Okay, thank you. We'll do that.
So I'll be third after.
Third after that. Okay? You want to? Go after him. After him. Okay. Thank you. So the list is very clear now. We have Mr. Bailey, Madam Konas, Mr. Janis, and then Mr. Mazier. 4 people on the list. So I would give the floor to Mr. Bailey. Mr. Bailey, please go ahead.
Thank you, Chair. Honorable colleagues, as conservatives, we've always
Point-
placed the health
So
and
point of
safety.
order, Mr. Chair. Are we speaking on amendments, right? Just want to
This
clarify.
is, we are speaking to the motion as amended.
Okay.
Right?
Main motions, okay.
No, main motion as amended
As amended.
by Dr. Strauss.
Okay.
Okay? Clear, Madam Sidhu?
Yes, Chair. Thank you.
Clear to all the honorable members? Yes, okay, thank you. Sorry, Mr. Bailey, please go ahead. Thank you for respecting that. As soon as the point of order called, if we stop, then it makes easier for the interpreters. Thank you.
Chair, honorable colleagues, as conservatives, we've always placed the health and safety of all Canadians at the forefront through practical, accountable, and result-driven policies that respect taxpayers and deliver measurable outcomes. We support this motion under Standing Order 108 for an urgent study on the rising rates of HIV infections in Canada, with particular focus on the public health emergency declared by the province of Manitoba. After years of federal Liberal management of health programs and coordination efforts, we are witnessing troubling localized surges that demand serious scrutiny, transparency, and concrete recommendations to protect vulnerable communities and ensure every dollar spent produces real results for families across the country. On May the 7th, 2026, Manitoba took the serious step of declaring a public health emergency because new HIV diagnoses have climbed dramatically from just 90 cases in 2019 to 328 in 2025, representing more than tripling in 6 years. In 2024, the province reported a rate of 19.5 cases per 100,000 people, which is over 3.5 times the national average of 5.5 per 100,000. Early data for 2026 already shows around 120 new cases in the first quarter alone, and projections suggest that without effective intervention, the province could face as many as 1,080 new cases by 2028. This crisis is compounded by rising syphilis infections, co-infections, and heartbreaking perinatal transmissions, with one infant born with HIV in 2024 and another in 2025. These are preventable tragedies that underscore the urgency of our work. Nationally, Canada has 2,288 HIV diagnoses in 2024, reflecting a modest 3.3% decrease from the previous year. Yet the national rate stands at 5.5 per 100,000 people. While some provinces show stability or slight improvements, the prairie hotspots in Manitoba and Saskatchewan, with rates of about 18.6 per 100,000 people in the latter. The overall picture is the wrong direction. Conservatives have consistently championed evidence-based policy making and proposed studies give us the chance to take a hard look at the questions about why, despite substantial federal investments over many years, certain regions and populations continue to experience escalating challenges. We must examine the data thoroughly, identify the gaps in prevention and care, and recommend practical solutions that prioritize outcomes over announcements. This study may pay close attention to the disappropriate impacts on specific communities as outlined in the motion. Indigenous people are tragically overrepresented in these new diagnoses, especially in Manitoba and Saskatchewan. Historical factors combined with ongoing realities such as remote geography, housing instability, barriers to cultural safe care, and intersecting social determinants have contributed to these disparities. Conservatives believe in empowering Indigenous communities with practical tools, supporting self-determination, ensuring sufficient use of funding through organizations like the First Nations and Inuit Health Branch, and delivering services that combine cultural respect and modern medical excellence. We need to hear directly from the Indigenous Health Organization about what is working on the ground and where federal supports can be made more responsive and less bureaucratic. Women in Manitoba are bearing a particularly heavy burden, accounting for more than 50% of the new cases in recent years compared to roughly 32% nationally. Many of these women are under 40, and the intersections with heterosexual transmission, injection drug sites, caregiving responsibilities, economic pressures, and experience of violence often delay testing and treatment. Conservatives support family-centered approaches that strengthen prenatal screening, ensure rapid linkage to care, and provide holistic support so that mothers and children can thrive. Even a single perinatal transmission is one too many, and our study must explore how federal prevention tools can better reach these women in real-world settings. In the two SLGBTQI+ communities, stigma continues to create barriers to testing and consistent care. Proven strategies such as regular testing, education on the risk reduction, and access to tools like pre-EP have shown success in the past when implemented, with clarity and personal responsibility at their core. We must build on those models while ensuring campaigns reach beyond urban centers into rural and northern realities where needs differ. Rural, northern, and remote communities face their own distinct challenges: long travel distances, shortage of providers, limited pharmacy access, and difficulty with follow-up care. Regions like Prairie Mountain Health and Northern Health in Manitoba illustrate these issues vividly. Conservatives understand rural Canada intimately, and we believe federal programs should cut unnecessary red tape, support effective telemedicine, and enable flexible delivery that respects provincial and local innovation, rather than imposing one-size-fits-all Ottawa solutions. Individuals experiencing homelessness, mental health challenges, and substance use disorders find themselves caught in a dangerous syndemic. Unstable housing increases exposure through survival, sex work, or shared equipment. Mental health struggles affect treatment adherence and injection drug use, particularly involving, I'm going to say this slowly so the interpreters get it, methamphetamines and fentanyl. Drives a significant portion of transmission in Manitoba, sometimes linked up to 70% of the cases. Conservatives advocate a balanced, compassionate approach to harm reduction. Needle exchange programs and supervised consumption sites can play a role in immediate risk. They must be paired with strong pathways to treatment, recovery, housing, and economic opportunities. Models that focus solely on enabling use without empathizing getting people healthy have not reversed border addictions and overdose crises in many cities. This study should examine integrated solutions that break cycles, then manage them indefinitely. Colleagues, turning to the federal role, Canadians rightly expect transparency and accountability for how their tax dollars are spent on health initiatives. The federal initiative to address HIV/AIDS and broader sexual transmitted and blood-borne infection efforts channel tens of millions annually, with community grants, surveillance, research, and awareness programs led by the Public Health Agency of Canada in coordination with other departments. We must scrutinize whether these investments are yielding the desired reduction in infections, particularly in hotspot regions. Prevention strategies include pre-EP scale-up, education campaign, condom distribution, for each and effective among high-need populations. Do current awareness efforts truly connect with the Indigenous audiences, rural residents, and those facing substance use in cultural, relevant, and direct ways? Testing and treatment access, including rapid point-of-care options and progress towards the 95-95-95 targets of diagnosis. Treatment and viral suppression deserve closer examination because gaps remain stubborn in remote and marginalized communities. Harm reduction initiatives warrant balanced review. While clean needle programs save lives in short term, conservatives stress that they cannot stand alone without robust emphasis on recovery and treatment on demand. There is a risk of normalizing addiction amid the ongoing fentanyl and methamphetamine crises that fuel injection-related HIV transmissions. Public awareness efforts must be clear, evidence-based messaging rather than vague approaches, and they should be tailored to Indigenous languages and formats that resonate with Northern and 2S LGBTQI+ audiences. Intergovernmental coordination between the Public Health Agency of Canada, provincial authorities like Manitoba Health, Indigenous organizations, and frontline providers is critical. Delays in data sharing or mismatches in funding can cost precious weeks or months in outbreak responses. This study should explore how federal levers can support provincial innovations without duplication or excessive bureaucracy. Witness testimony will be invaluable. Officials from the Public Health Agency of Canada can detail national surveillance systems and response times to Manitoba's alert. The Minister of Health should address accountability for outcomes and any coordination bottlenecks. Representatives from Manitoba Health can outline specific federal supports requested versus those received and how emergency measures are unfolding on the ground. Indigenous health organizations will bring perspective on culturally safe models and funding efficiencies. Frontline community organizations and medical experts can speak to daily barriers and clinical innovations, while individuals with lived experience offer powerful insight into what actually turns lives around. Whether through consistent treatment adherence, stable housing, or recovery-focused programs, at least 2 dedicated meetings provide a foundation, but we should be prepared to dig deeper into the program, evaluations, and return on investment analysis. Past reviews have not gained in awareness and knowledge exchange, but weaker performance on concrete infection reduction metrics, and that pattern must change. The proposed timeline matters deeply. A reporting deadline of July 22nd, 2026, combined with the flexibility for summer meetings if the House rises, and authority for the Chair to schedule sessions, plus the ability to seek House permission to table the report afterwards, demonstrates that the committee takes the active public health emergency seriously. Manitoba's situation cannot wait until fall. Conservatives have always pushed for efficient use of parliamentary time that puts people ahead of procedural delays. A focused report emerging from this work can deliver actionable recommendations on immediate federal levers such as an improved data protocols, targeting funding pilots for rural infrastructure, reduced administrative hurdles, and balanced harm reduction paired with recovery metrics. Let us consider the broader context and lessons from history. Canada has made meaningful progress against HIV over decades through scientific advances, community dedication, and focused policy. Previous Conservative governments emphasized strong surveillance, targeted funding, and measurable accountability. In recent years, despite continued or increased spending in some areas, we have seen these localized surges that reveal gaps where social determinants, chronic housing shortages, and the addiction epidemic, family breakdown, and the economic pressures intersect with health delivery. We must learn from jurisdictions and models that successfully balance biomedical tools with behavior, prevention, personal models, responsibility, and the recovery pathway. Strong border controls against importing illicit drugs, support for law enforcement tackling fentanyl networks, and economic policies that lift people out of poverty all form part of the comprehensive national strategy. To expand on Manitoba's emergency in great depth, the tripling of cases from 90 in 2019 to 328 in 2025, the fact that more than half are among women under 40, the regional concentration in Prairie Mountain and northern health areas, and the syphilis co-infection surge all point to a syndemic that requires coordinated action. We should ask witnesses what precise federal resources Manitoba requested and whether delivery was timely. How can successful provincial testing expansion, PREP, outreach, and community initiatives be amplified nationally while fully respecting jurisdictional roles on Indigenous health? The overrepresentation demands attention to self-determination, efficient funding flows, and integration of traditional knowledge with evidence-based medicine. Flexible block funding models that let communities set priorities could yield better results than top-down programs. Rural and northern access issues deserve extended discussion. Transportation barriers, pharmacy shortages in remote areas, and specialist wait times are not abstract. They prevent people from staying on treatment and achieving viral suppression. Conservatives favor federal transfers that empower provinces and territories to innovate with mobile clinics, provider incentives, and technology solutions tailored to local needs. The substance use dimension links directly to the wider opioid and stimulant crisis. Data shows injection drug use driving many Manitoba cases reinforces the need for oversight in a safer supply approach and a clear priority. Manitoba case on treatment first model, comparing outcomes between recovery, focused programs, and harm reduction only approaches will provide valuable evidence for recommendations. Federal funding deserves rigorous value for money scrutiny. Tens of millions flowing annually through the federal initiative, yet outcomes in prairie provinces lag. We must trace multi-year allocations, examine the history of underspending or inefficiencies, and calculate the true return on investment. Lifetime costs of antiviral treatments for one person run into hundreds of thousands of dollars, making effective prevention not only compassionate, but financially responsible. International and historical comparisons can inform our work. Canada's progress towards UNAIDS targets in hotspots versus other countries that have achieved sharper declines through combined strategies, lessons from the 80s and 90s responses, which paired medical advances with clear behavioral messaging, remain relevant today. In preparing for witness sessions, yes.
I'll give you a couple of minutes.
Good, yeah.
A minute if you want.
Okay.
A break.
So I think my point that I'm trying to get to the committee is I did investigate all these 3,400 studies. Yeah. Yeah.
You have a minute only. I meant I give you a minute of a break.
Oh, I'm good.
Okay.
Well, unless you think the interpreters need a minute break.
Okay, no, they're good.
They're good?
Okay, yeah, you continue.
Thank you.
Sorry.
No, I'm good. In preparing for witness selections, the committee members might consider targeted questions. Now, this is every new infection carries profound personal, family, and societal costs beyond the human suffering of diagnosis. Treatment adherence challenges and stigma, there are substantially long-term healthcare expenses that strain provincial budgets and federal transfers alike. Prevention through smart, practical policies saves both lives and money. This study allows us to honor those living with HIV and those at risk by converting testimony into tangible improvements, reducing new cases through better coordination, efficient spending, and policies that work for rural families, Indigenous communities, women, and individuals battling addiction and homelessness. We can return to the core statistics repeatedly for emphasis. Manitoba's rate remains dramatically higher than the national figure. The women's share of cases exceeds national averages significantly. Indigenous overrepresentation persists, and injection-related transmission intersects with the broader drug poisoning crises. These patterns have developed over years, and a thorough committee examination offers the best path to course correction. Conservatives stand prepared to collaborate constructively on a report that prioritizes vulnerable Canadians, demands accountability from programs, and charts a pragmatic path forward. By supporting this motion and conducting the study with diligence, even through the summer if required, we fulfill our duty to evidence-based governance and the health of our nation. Continuing with further details on prevention strategies, PREP has demonstrated high efficiencies when adhered to consistently, yet real-world adherence in unstable housing or active substance use situations can falter. Education on condom use, partner communication, and regular testing remain foundational. Conservatives support comprehensive yet responsible education approaches that include personal agencies and health decision-making on the treatment cascade. Shortfalls in diagnosis rates, timely initiation of antivirals, and sustained viral suppression in high-risk cohorts need addressing. Some studies show lower suppression rates among certain Indigenous persons who inject drugs, heightening the need for wraparound support. Harm reduction balance is essential. Acknowledging the lives saved by clean needles does not preclude recognizing data that links unchecked drug use to ongoing transmission. We should advocate for housing first model paired with treatment, enforcement against dealers fueling the crisis, and metrics that track movement towards recovery rather than perpetual harm management. Public awareness campaigns have sometimes fallen short in measurable impact. Direct audience-specific messaging via Northern Radio, Indigenous storytelling format, and clear school programs on healthy choices could strengthen outcomes. Intergovernmental coordination benefits from the national standard that do not override provincial flexibility, drawing best practices from other federations, and creating rapid funding mechanisms for declared emergencies. The human stories behind the number deserves reflection. Imagine a northern community member describing multi-day travel for medication refills, or a woman facing caregiving duties while managing her own diagnosis, or an Indigenous leader outlining successful community-led testing combined with cultural supports. Generalized examples from lived experience illustrates how fragmented services prolong suffering while integrate recovery programs restore hope and productivity. These voices must inform every recommendation. Colleagues, this study represents more than procedural work. It is an opportunity to move beyond rhetoric towards actionable, compassionate, and fiscally responsible solutions. Conservatives stand ready to collaborate on finding that protect the most vulnerable, hold program accountable, and reverse these concerning trends. Let us approve the motion, conduct the study thoroughly, and deliver a report that serves all Canadians. We have ample material here to explore each theme at length, pose additional questions, examine hypothetical scenarios from witness testimony, and reiterate the call for practical outcomes grounded in evidence and common sense. By doing so diligently, we hold up our share of responsibility to public health and the well-being of our nation. Thank you, Chair.
Thank you, Mr. Bailey. Very good pace. Appreciate that. And no disturbance, though I appreciate the other members as well. So now we will go to Madam Konaz. Madam Konaz, floor is yours.
Thank you, Chair. I'm, as I mentioned in the last meeting, this study on HIV is extremely important, and I'm hoping we can move forward with it as soon as possible. But as mentioned, we need to make sure that the members around this table commit to a prescribed IT investigation before the summer. And but the reason why I don't even really think I need to tell anyone around this table or the public who are watching the importance of this study in Canada right now and throughout the world. But in Canada, that's what is the focus. The focus is going to be because it's obviously something that we needs attention right now, similar to our motion for Ebola. That is a on-the-ground boots, something we need to look at as soon as possible. That was turned down by the Liberals at this table. But moving on with this HIV study is extremely important because we all know years ago when HIV and AIDS was first diagnosed and hit our world, it was horrible. It was a horrible, terrible time for all of us. I was living in Los Angeles at the time, and as you know, in the 80s, it was one of the ground zeros for AIDS and HIV. I had quite a few people that I knew who contracted AIDS at the time, and also people I didn't know, but there was so little known about it that it was people were dying right and left, and as many people around this table, I'm sure know some people who have died of this, and it is an agonizing death at the time. Obviously, we have medication now that helps prolong life, which is a miracle and goes in and can be credited to the research that was done by scientists at the time and continues to be done. I have family members that contracted it, unfortunately, and I also have a family member who died, not of AIDS, had AIDS, but it was years and years of having the disease that affected his mental health, and he committed suicide. And it was devastating to our family. So to hear that this is raising its ugly head again, there's no way that we especially through the summer, we shouldn't be able to do this research and go and at this committee. But one thing that's interesting is that there is, if you go online, there are, as was mentioned by my colleague, there are hundreds and hundreds and hundreds of research projects and scientific studies that have been done on AIDS and HIV, even some just recently. And so we have to make sure that let's not waste any time with it. When we do pass this eventually, of course we will need to do this research. We need to make sure that we bring in the latest findings, not there's a lot of research that's been done that's sitting on shelves collecting dust. This needs to be current. And if you look at the studies, as my colleague, Mr. Bailey mentioned, a large percentage of the AIDS patients right now and people with AIDS and HIV are those that have been using meth and fentanyl. Because drug addiction has become, in the last decade, it's become rampant, and it's out of control. I'm sure it's out of control. Drug use for every person sitting around this table sees drug addicts walking around their cities, towns every day, something we never used to see before. Parents are going to playgrounds with their children, making sure they do a sweep of needles before the kids can even play, can even use the playground, which is something we never had to do 5 years ago even. And we know that those needles may have diseases and are including may have been used on somebody with HIV and AIDS. So the study that we do here has to focus on that, and I'd like that to happen with including research in rural towns, as I mentioned last time when I spoke. It needs to be done in rural communities like my own. And also, as I mentioned before, the Similkameen, South Okanagan, West Kootenay is one of the highest senior populations. And as I mentioned in the study that was done in the last on Tuesday, the study I quoted, it's really hard to tell the difference between somebody who has AIDS somebody who has HIV and in an older population, especially if that person, as the thousands of people in my riding do and throughout Canada, don't have family doctors, so they cannot be diagnosed properly. And even with family doctors, somebody who hasn't seen these type of symptoms before may get it wrong. So this is going to will need to be part of this study. There's a couple of studies that have been done recently in 2025 that are studies that have been done in Canada. And we maybe want to get one of these scientists in here to speak about this, but one is Hopwood, Sang, and Sheehan their study in 2025 is called Change RX, Frailty Falls, Polypharmacy, and Inappropriate Medication Use. The other study is, excuse me if I'm talking too loud, too fast, I'll try to slow it down just a bit. Collins, Cunningham, and Vaughan, promoting, and their study in 2025 is called Promoting Healthy Aging in People with HIV into a New Era. So there's studies coming out on, in particular, HIV and the aging process. The Canadian study, these studies explore links between frailty, falling, and excess medications in people with HIV. As people with HIV age, their burden of non-HIV medications can increase. Researchers found that more than 50% of older adults with HIV take at least 5 non-HIV drugs. Taking 5 or more non-HIV medications was associated with an increase of frailty and falls. Again, adding, not only is that difficult for the person with HIV, but it's also an incredible burden on our already burdened health system and overcommitted hospitals. Thanks to HIV treatment and antiretroviral therapy, many people with HIV are living long, healthy lives. The impact of ART is so profound that researchers increasingly project that many ART users will live well into their senior years. But as they age, the risk for comorbidities increases, just as it does for people without HIV. Older people in general tend to have health issues such as high blood pressure, high levels of cholesterol, and so on. As they age, people with HIV are being prescribed more medicines to manage these comorbidities. Researchers have found that older people without HIV are taking multiple prescribed medicines for comorbidities called polypharmacy. Studies have found that although multiple medications may be necessary for some people, in other people, the prescriptions may be excessive and may increase the risk of problems such as falls. And of course, this becomes even more prevalent when the doctor, the prescriber may not even know that the person has AIDS. A team of researchers involved in this study called Change HIV analyzed healthy related information collected from 440 older people with HIV at 7 major Canadian clinics. They were aged 69 years or older. 92% were assigned were male at birth. 8% were female. Major at birth. The racial groups were white, 76%, black, 13%, and they all were diagnosed with HIV for at least 26 years. Continuing on. In reviewing the data, researchers made the following findings about all the participants. 16% were frail. 21% had experienced a fall in the past 6 months. 54% had polypharmacy, were taking 5 or more non-HIV medications. Nearly 50% had what the researchers called potentially inappropriate medications. And the most common comorbidity were abnormal lipid levels, high blood pressure, and cancer. As mentioned earlier, doctors prescribe medication to manage these comorbidities apart from their intended effects. Some medicines can have side effects. Specifically, they assessed the participants' non-HIV medications to find out if they had an inhibiting effect on the neurotransmitter, I'm sorry if I'm going to pronounce this wrong, acetylcholine. And is that okay? Acetylcholine, thanks. They were interfering with messages sent between cells, particularly between brain cells or brain cells and the nerves and muscles, and could increase the risk of dizziness and falls. Statistical analysis found that in participants who had a high burden of these drugs or other drugs that cause them to be drowsy during the daytime, the risk of frailty was increased about 3 times above that of people who did not have a high burden of such drugs. According to researchers, the most common I won't say the most common PIMs were proton pump inhibitors, aspirin, testosterone, or benzodiazepines. For every additional PIM, researchers found that the risk of falls increased by 25%. The analysis showed that doctors prescribe medicines to treat or even prevent comorbidities. Sometimes it is medically necessary for people to be taking many non-HIV medications, and so this is often the case after obviously a heart attack or stroke or people with multiple or complex underlying health conditions. In some cases, a person's health changes and may no longer be necessary to be on those drugs, and because they and they may not need to be on as many non-HIV medications as before. So they need regular checkups with their physician, and pharmacists can be useful, which is useful. But as we know, many people don't have a family doctor, or don't have doctor, and have to go into a walk-in clinics and or into the emergency room, and their particular drugs are these particular drugs are not going to be checked for that many times. So there's a worry of that. So studies that were done in Switzerland, the UK, and other countries suggest that as people with HIV/AIDS and accumulate comorbidities, their risk of polypharmacy increases. These studies support the findings from Change HIV, this report. The researchers noted that participants were overwhelmingly male and a majority were white. This may limit the findings, and which is why we need to look at this further. The Canadian researchers encourage clinicians caring for people with HIV to incorporate a geriatric approach to managing non-HIV co-medications and evaluating their anticholinergic and sedating properties. The researchers made the following statement: addressing polypharmacy, PIMS, PIMS, anticholinergic and sedating medications should be prioritized in older adults living with HIV. Identifying and prescribing or tapering some of these drugs would be a reasonable first step that can be accomplished through a clinic visit. Again, we have to make sure they're able to make that clinic visit. And there are multiple tools, including clinician-focused websites that can provide guidance on how to safely de-prescribe medications. Anyway, I think before I'm going to let my colleague continue, but I just want to say that we need to make sure that we move on with this study as soon as possible, and which is why we're looking forward to seeing the Minister of Health and Michael Green come to this committee and speak with us about Prescribe IT. Thank you, Chair.
Thank you very much, Madam Konas, for the pace. And now we will go to Mr. Janis. Mr. Janis, floor is yours, and the topic is on HIV.
Thank you, Chair. I appreciate the opportunity to be here. It's good to see you in the chair. I fondly remember our days of working together on the Immigration Committee and various other places, and I know we've had lots of good discussions about various issues, domestic and international, over the years. So it's good to be here at the Health Committee and supporting my colleague, subbing in for Mr. Strauss, who I know has distinguished himself in many ways already in his early career as a parliamentarian and as a doctor. We don't end up with a lot of doctors in Parliament, so it's an honor to serve with him. I'm married to a doctor, which is not the same thing, needless to say. But so does Mr. Bell. Okay, all right. Chair, I'm pleased to speak to this motion, and I do think it's important to kind of provide some context for where I see this motion coming from, and I want to try to be careful not to be too definitive about the motives of some aspects of this, but this is the sort of thing we have seen before at other committees in my experience. So there are different aspects of the context. So this is a motion that essentially proposes to set aspects of the committee's agenda. So it's an agenda scheduling motion, and it has various provisions around a particular study, a study on HIV and syphilis, but it also has various other elements of scheduling, prescribing a minimum number of meetings, potential witnesses. This motion also involves proposals for summer work. I do want to commend the committee for that interest in in doing committee work during the summer. I've generally been of the view that that committees can and should do work from time to time during the summer, not only because I fundamentally enjoy committee work, but also because for better or worse, we have now the tools of virtual parliament. So when there are big emerging issues for members to, if they're not able to travel to Ottawa, for them to be able to do a 2-hour meeting or a few 2-hour meetings in the summer, it doesn't dramatically cut into what they're otherwise doing in the summer, when we're primarily, of course, focused on engaging with our constituents. So the motion does involve continuing to work into the summer, which I commend the committee for its willingness to do. I'm on the Human Resources Committee, and we had tried to get a study of youth unemployment going last summer, which I saw very much as an urgent situation, and sadly there wasn't appetite on our committee to do that. So maybe in that regard, I would be hopeful that this might reflect a trend across different committees of willingness to take on important public issues during the summer break. Having said that, though, I think there's another piece of context here, which is that members of this committee have been doing their best to get to the bottom of a major IT scandal within this Liberal government. That is the prescribed IT scandal.
Point of
you
order,
have a
Mr. Chair.
motion.
Mr. Chair,
I'm sorry. Can I get? Is there a headpiece? Sorry, I'm just.
a clarification. I know. I think last 2 days ago or 2 weeks ago, when we said filibustering, Mr. Bailey said Mr. Janu is not here. So I'm just they are not filibustering,
It's
right?
okay. We'll give Mr.
Oh,
Janis, Mr. Janis the floor. Mr. Janis, we can keep our comments to HIV and syphilis related, that will be much appreciated. So please go ahead. Floor is yours.
Thank you, Chair. I think it's fairly obvious that that's precisely what I was talking about, and I appreciate your clarification of that for Ms. Sidhu. We're discussing a motion on scheduling the work of the committee, and there's a proposal in this motion in terms of scheduling for a particular motion to be scheduled. That is a motion on HIV and syphilis. And the context of that scheduling request, I think, has to include the other items that the committee has on its agenda or prospective agenda. I know this motion was moved while another study was on the floor at a previous session of the same meeting, and this was also moved in the context of the committee undertaking efforts to prosecute the prescribed IT scandal. And the opposition members of the committee have been, I understand, united in requesting certain information about that scandal and the appearance of the minister as well as some central figures involved in that scandal. So sometimes what you have procedurally at a committee is you have efforts by the opposition to study an issue that is, frankly, potentially embarrassing to the government. And then the government puts forward a study on a legitimately important issue, but they do so with impure motives. That is, they do so with the goal of displacing what otherwise is the important work of the committee, holding the government accountable for a scandal. So you have at this committee efforts by the opposition to say hundreds of millions of dollars wasted on a system that was quietly discontinued. Where did the money go? And then you have a motion put
Mr. Janis,
forward.
Please,
on.
I would like you to focus on HIV and syphilis because I want this committee to function smoothly, and it was functioning very smoothly with Mr. Bailey and Madam Konar speaking, and I don't want back and forth going. So I know you have, a lot of experience. The only reason is because last last meeting or meeting before, your colleagues made a point, some kind of intervention that, oh, we haven't brought Mr. Janus in, so to filibuster. So I just don't want that impression to go out. So because you're a very respectable member and very knowledgeable and very much to contribute. So let's focus on HIV and syphilis-related issues. Thank you. That'll be very kind.
Yeah, thank you, Chair. I certainly intend to be very kind in my intervention, so thank you for that. I do want to say that I will look. I'm going to comport myself in accordance with the rules, which I know you will enforce as chair. But there may be a difference between the things you want me to talk about and the things that the rules prescribe in terms of what I can talk about. I will be very much on the topic of the motion. The motion is a scheduling motion. That is, the motion proposes that the committee study certain matters, and in the process of studying those matters, not study other matters. So the question of whether the committee studies HIV and AIDS right now, according to this motion, is a question of the committee's agenda, is a question of how the committee manages its agenda. And so I think it's natural that we would have a discussion of the committee's agenda in the context of that and alternatives. So simply to say that you have a context in which Liberals bring forward this motion on HIV and syphilis, while there is an effort at the same time at the committee to pursue this matter of the prescribed IT scandal. And it might appear to the public that the government is putting forward this study with the goal of displacing potential discussion of prescribed IT. And I think probably what the public would want is that we look for a way to respect the seriousness of the subject matter of this motion, while also addressing the issue of prescribed IT, that we not allow one issue to displace the other, but that we take an approach that respects the importance of both
Point of
issues.
order, Mr. Chair. Mr. Chair, I really want to object this. My colleague, his hometown has an emergency situation. This is why we bring this motion. And Mr. Janu, who is not permanent member of the committee, I just want to let him know why this motion is important for my colleague. Thank you so much.
Just on the same point of order, I'll just observe that having a different opinion is not a point of order. The member's welcome to be on the list.
Let me put it this way. Right now, the motion in front of us is not the prescribed IT. It is on HIV and syphilis. And we cannot presume either what the motives of the opposition are or motives of the government are. So I would request on members on both sides not to get there. Let's focus on a very important issue that's in front of the committee right now, which is a study. Particularly, we have Mr. Mazier and Mr. Eopson from Manitoba. That's where it started. That focus is on the HIV, the people dying with HIV in Manitoba. And when the prescribed IT program comes in, I will give all the time to the speakers, and that's what I always intend to, because I don't want to interrupt you, Mr. Janus. I just want this committee to function well, because I don't take this position, to embarrass anyone. The prescribed IT is not the subject matter of this motion. So I would like you to focus, and this is not a scheduling either, because all we did is, right now, is studying that motion, right? And we should focus on that motion, please. I would really, really appreciate it. It will make my life easier, and it will make the committee work very cordially as well moving forward.
Yeah. Well, thank you, Chair. I know my constituents' primary expectation of me is that I work hard to make your life as easy as possible when I'm here. So I will. I'm just teasing.
I have
Mr.
no
Chair.
doubt that you don't work hard. You work very hard. I commend that.
Thank you, Chair. I was Ms. Sadu, you've asked me not to be too definitive about suggestions about the motives of members, and I do respect that that rejoinder. I think what I was sort of working up to is we have an amendment to this motion that if passed, I think would make the motion very fair and supportable. It's to try to establish the conditions in which the work of the committee can unfold in a way that would be respectful of the work that we are trying to do on Prescribe IT, but also respectful of the desire to proceed with a study
Point of
on
order,
HIV
Chair.
and syphilis.
Just point of order, Chair. Thank you, Chair.
Sorry, this is point
I
of
just
order.
want to clarify. I know Mr. Genuis was mentioning an amendment. I think my understanding is that we're debating on the main motion, right? Can I just get some clarification on that?
This is the motion as amended, but this amended motion does not have anything to do with prescribed IT. It has, it only sets up the deadline. That's it. It's not even scheduling anything. I mean, the meetings, 2 meetings, and he can talk about those meetings that are part of the scheduling. How many meetings had to be scheduled? Who is coming in? And when those people come in, those questions can be asked. I would not stop you asking questions on any other subject either. But right now, my focus is to get this motion off the floor, so we can move on with the next study. So it does not say scheduling. It only says when it comes to scheduling is particularly to this motion, to HIV and syphilis motion, how many meetings, who's going to come in, and that's where our focus should be. Thank you.
Yeah, thank you, Chair. Can I, if I can just respond to the parliamentary secretary? So she's correct in pointing out that there is no amendment currently on the floor. What I had said is I was working my way up to proposing an amendment, but explaining a little bit of background on that. So there is not currently an amendment on the floor, but stay tuned. There will be one on the floor in about 90 seconds if there aren't any intervening points of order. If there are, then it will be a little more than 90 seconds. The amendment to this scheduling motion proposes to establish in the scheduling of the study of HIV meetings that would also be set aside for a discussion of Prescribe IT. And that would allow the committee to undertake studies on both of these issues and to do so within the timeline prescribed. So if I could, I understand a version of the amendment was previously sent to the clerk embargoed, so if I could ask the clerk to distribute that to colleagues, and I will read the amendment as it is.
And then I'm not going to give in advance, okay?
There's 2 of us.
No, I tell you right now, I will see the hands up. First of all, let me focus on his amendment. And I can't prejudge but who is going to speak, and then I will give every member an opportunity to raise hands, and then I'll figure it out who I'm going to give the time to.
But Madam Clerk, you've got that amendment, and you can distribute it as I read it.
Suspend to distribute.
Okay.
to order and suspend the meeting till Tuesday.